So we give them a movement hack. Let's say their hips and knees are good. If their hips and knees are good, I'll say, stand up, put your foot up on the chair instead of sitting on it. Now, take your hips to the target. Watch what happens. When I take my hips to the target, I let my knee drift over my foot. Look at my back. I'm not going near my pain trigger. I tie my shoe. Out I come, pain-free.
Hello, I am Celia Sanker, Executive Director of the Diversity Canada Foundation, the organization that brings you GoldenVoices.com, the online platform where seniors gather to focus on issues of importance to seniors. At GoldenVoices.com, you'll find our Golden Years Fireside Chat series, where we speak with experts and everyday seniors about topics under the theme of living longer and living well. Today we will be speaking with Dr. Stuart McGill. He is a Professor Emeritus who was a professor for 30 years with the University of Waterloo. His laboratory and experimental research clinic investigated issues related to back pain, how to rehabilitate those suffering with back pain, as well as performance and injury resilience. His work produced over 240 peer-reviewed scientific journal papers, several textbooks, and received many international awards. Dr. McGill continues to explore the subject as the Chief Scientific Officer of BackFit Pro, and you can find their website at backfitpro.com. His advice is often sought by governments, corporations, legal experts, medical groups, as well as elite athletes and teams from around the world. He has mentored over 37 graduate students during their scientific journey. So thank you very much for joining us today, Dr. McGill. Or
Well,
shall
good morning.
Shall we say Stuart?
Please, yes. Good morning, Celia, and thank you very much.
Before we get deep into the subject, would you first tell us a bit of your background? This seems to have been a life passion for you.
Yes, I did my PhD in spine biomechanics, and I only had one question when we started, and that was simple. How does the spine work? And we enhanced a laboratory that measured stresses inside the body with people doing different things. And lo and behold, the areas of high stress is where the back pain emanated from in many cases. Then I developed another laboratory where we took cadaver spines and loaded them and watched the changes so we could correlate what injuries were caused by specific mechanical scenarios. Then I started a research clinic to test whether or not what we were converging on was helping people, and also to develop a very thorough assessment. Which is probably one of the most extensive assessments of back pain available today. And then the finishing bit was I would be asked to see special people, quite often elite athletes, because they stressed their bodies to the limit. And could we come up with ways for them to stay below the biological tipping point so their training built them up to the tipping point, but they don't cross the tipping point into injury? So we learned a lot on what is biologically possible with looking at some of the most elite forms of our humanness on the planet. So that was a little bit of the story. And of course, we wrote scientific papers and tried to unify them into textbooks for consumption by students. And then finally, my last book was for the lay public.
And what set you as a student in this field?
It was it was a combination of my personality, I suppose, and then just those dumb luck stories of life. I really, I have to tell you, in high school, I didn't want to go to university, and I went more I was interested in sports at the time, and then my master's degree, I went to the University of Ottawa. Uh, I studied biomechanics, but they had lovely cycling in the Gatineau, just north of Ottawa. So it was a very attractive place for me. But then the University of Waterloo had an outstanding program, and my mentor there, Professor Bob Norman, was an outstanding mentor, and that's why I ended up going there. But I think it was my personality to try and become a master of the craft. And it doesn't matter what the craft is. Right now, I'm retired too. I still have a small clinic here, but I practice welding and things like that, trying to master the craft of welding, just as I tried to master the craft of assessing a person's back pain to really understand the mechanism so we know how to deal with it.
That's wonderful. So, life channeled you in that area so that you could study intensively this issue and not today provide relief to so many others. And that's great. Okay. So, in terms of back pain, when we're talking about back pain, there is a term that from listening to your talks and reading what you've written and interviews with you, it seems that you don't like that term at all. It's one used by the medical fraternity, and that is non-specific low back pain. Would you explain to us what that is and why it's not one of your favorite terms?
Yes. Let me just have a little bit of fun with that concept. Have you ever met anybody who has non-specific leg pain? People wouldn't put up with that. I go to the doctor, oh, they diagnosed me with non-specific leg pain or non-specific head pain. Why do we put up with that with the back? All it shows is they never had a thorough enough assessment to converge on has their back been fractured? Do they have a disc herniation? Do they just have muscular fatigue? And if we can get a precise uh, understanding of the mechanism of the pain, A, we know with precision how to avoid the cause, and B, we then know how to create an antidote, so to speak. I can give you lots of examples of that, and then build a foundation for pain-free movement. So I hate to use this word, but it really is a garbage medical diagnosis, and it gets some clinicians off the hook. Oh, well, I've given them a diagnosis, off they go. But it's just such an impediment for people. But here's the rub. In the medical system, clinicians are paid to perform billable codes or procedures. There's no code for an assessment, so they don't get paid to do a thorough assessment. We broke the mold on that a little bit because we cannot proceed without a thorough assessment.
That term, non-specific low back pain, that's not something that patients should accept as a proper diagnosis.
Well, would you go to your car mechanic and they come back and say your car has non-specific problems, we'll change the engine?
Yes.
You don't put up with these things in other parts of your life.
So, how much of a problem is this? Not just the term non-specific, but back pain, low back pain for those who are 65 and up, older adults.
Well, I'll start by saying there certainly is a character to the back pain mechanisms as we age. So when we're younger, the problems tend to be what we call discogenic, due to the disc. So I could give you a few models here. There is a section out of my low back of a spinal joint. Now, it's not like a hip joint that's a ball and socket. The spinal joints, the discs are actually an adaptable fabric. They're made up of many collagen fibers, like my shirt is a fabric. Now, when you're young, you have lots of mobility, but this fabric moves back and forth, which creates stress strain reversals. So if I wanted to work a hole into my shirt, I would reverse the stress strain back and forth, and the fibers would delaminate. Well, when you're younger, some people, not all, but some, will train, or because of their job or for whatever reason, they have too much spine movement with too much load. So you can have a lot of spine movement without much load, and it's not really an issue. Or if you have a lot of load, try and back off on some of the movement. Use your hips instead. But here's generally what happens with younger people. There is at the end of my finger some collagen that has delaminated. You'll see that little red mark in there. So some fibers are starting to delaminate. I'm going to squeeze and bend the spine forward, and you see the fibers opening up, and there's a gel inside the disc. It's called the nucleus, and that gets projected posteriorly with hydraulic effort because you're bending forward, and that would cause a disc bulge. This is the nerve root that exits by the bulge, and there's one at every level in your spine. So younger people tend to get things that cause pain like disc bulges and that sort of thing. But when we're older, the discs get stiffer. The gel dries out a little bit. So then another category of back pain starts to become a bit more common. So when I was younger, I would have bouts of discogenic back pain. That's all gone now. And as we get older, there's a bit of arthritis that grows, and you can see this gnarly looking bone around the facet joint, and there's some gnarly bits around the disc. All these models, by the way, are made by a company called Dynamic Disc Designs, and they're the most biofidelic models to explain to people the mechanisms of pain. So the spinal cord, represented by this brass rod, runs through a canal. As the arthritis grows, as you get a bit older, and the joints settle down, and you know you're not as tall now as when you were a younger woman. I've probably shrunk an inch now, and I'm in my mid 60s. As the height of the joint decreases with age, you know, if you let a little air out of your car tire, a bulge forms in the wall of the car tire. Well, so too does a bulge form all the way around. This is a very different type of full radial bulge. But then it captures the nerve root a little bit so that there's friction on the nerve root as I slide it. Because when you're younger, you can see how the spinal cord slides up and down very freely. And so that stops the person from getting pain when they move their neck a certain way and move their leg a certain way. This rope of the spinal cord just simply slides as it's supposed to do. But as you get a little bit older, as that canal starts to shrink in size a little bit, the flossing action of the nerves is impinged just a little bit. So there's the posture of the spine, and we see the brass rod moving very well. Now I'm going to flex it just a little bit if I can, and now I'm going to extend it just a little bit if I can. And when I extend it a certain way, you'll see the brass rod is stuck. It doesn't move. So you've heard of older people who say, well, I've got spinal stenosis. My feet are going numb. I've got pain in my anterior thighs. It used to be when I was younger, I could walk and that gave me relief. Sitting down at the computer and watching the television caused me back pain, but now it's the polar opposite. Sitting is my relief, and walking is causing my pain. So there's just a little bit of a very general 5,000 feet down view of how your spine changes. And obviously, how you would approach each of those is very different through the life cycle as well. So when you ask me how much of a problem is it, it depends on the person. I've met 80-year-olds who are chronologically 80, but their spine looks like a 40-year-old. do you see what I mean? Chronological age and biological age, they don't match. But typically, those who have developed an awful lot of athleticism, a lot of weight training, a lot of heavy motion, they tend not to keep that quite as long as the person who's more moderate in the exposure to loads and motions. So it's interesting. You don't see too many world-class Olympians who are masters champions when they're 70. They tend to be a little bit more worn, if you know what I mean.
Yes, so they would have pushed the body perhaps too far, and they can't maintain that the levels of fitness into their older years. Their spine has been pushed to its limit.
Well, their spine, and they tend to have more hip replacements and knee replacements. And, this is the funny part of life. My father was a good Irishman, and he used to say, moderation in all things, but a little bit of what tickles your fancy is good for you. And that certainly would hold true for lifelong spine health. If you're an absolute couch potato, you are increasing your risk as you age. And if you're really pushing the biological limits of weights lifted and speed and motion, chances are you will accelerate some of the arthritic changes and those kinds of things. So it's better to be moderate in all those things for a greater chance for having a lifetime of a problematic spine or knees or hips or anything else.
As we age, this problem begins to increase. But so why isn't there a solution that's more readily available? Why is it that seniors who have this problem can't find a lasting solution?
Well, some can is the answer, but I come right back to this notion of many, and I'm seeing an 82-year-old in the clinic this afternoon. I've already looked at their MRIs, and I've read their symptoms report and their diagnostics reports from some of the imaging studies as a beginning on all of this. Not once has anyone ever assessed this patient to know whether what they're seeing on the images actually do correlate with their pain. So that's the biggest impediment, and I suppose it's the fundamental answer to the question. But having said that, not all things can be addressed. Sometimes it's just a bit of bad luck, and things. Many things can adapt, and certain things don't.
In your work, you mentioned something called pain triggers. Would you explain to us what those are?
Yeah, I could probably do that best with a demonstration. So I'm just going to turn my computer screen down, and I'm just sitting on a stool here in the clinic. So let's say a person comes in, and I'll start a little bit of a pain provocation assessment. I want to purposefully see if I can detect their pain triggers. So observe as I'm going to sit. My first move was I collapsed my spine rather than moving my hips back. So I've already created a stress concentration to certain parts of my back, and I plop down and I sit like this. And I'll say to the person, are you uncomfortable? And they might say, no, not really. That's fine. Or maybe they do. We'll see which way it goes. Then I'll say, sit upright, lift your tail behind, suck a little bit of air. Do you have any pain? And they might say no. And I say, good. Well, let's load that. Grab the seat pan of the stool and pull up with 20 pounds on each arm. So you've just loaded your spine with 40 pounds. Does that cause pain? No, that doesn't cause pain. Then I might say, okay, slouch, drop your chest down. Does that cause pain? Oh yeah, there's my pain. So immediately I've just found what causes their pain in terms of a posture. Now I'm going to change the length and stress in the spinal cord. I'll say, now flex your neck and look down. And they might say, oh, you just took my pain away. Oh, look up. Oh yeah, There's my pain, it's even worse. So what I'm showing there is an underhook on the nerve root. The nerves slide as a function of what neck motion is occurring. So as they look down, they're going to pull the spinal cord up, and watch this nerve root under my thumb. Do you see it pulls it off? If there was a bit of arthritic bone there, I'm pulling it off the offense. But when I look up, watch the nerve root right there, it gets pushed down into the offense if there was some arthritis there or a disc bulge or whatever. So we put together these patterns of specific activities, motions, postures, and loads, but it just might start with a simple sitting assessment. Or I might simply have them stand upright like this, and they'll say, oh, I've got muscular backache, and they're standing like this. My head is ahead of my hips and my low back. Well, if I asked you, Celia, to hold a pound of butter in your hand and walk around with that pound of butter like this all day long, you know at the end of the day, your bicep muscles will be screaming. Now, what's the solution? Simple, put down the pound of butter and straighten your arm. This is what people do unknowingly. So if I then show them, can you pull your ears over your shoulders, shoulders over your hips? Now, before we start that, feel the back muscles either side of your spine. They're rock hard. They are contracting, supporting that head forward posture. Pull your head back, and maybe I have to adjust the hips forward. We'll play with the strategy, and then they feel the muscles go quiet, and they'll say, oh, doc, you're magical. You just took away my back muscle cramps. And I'll say, good, there you go. Now we understand the mechanism of your muscular pain. I just gave you a strategy to take the pain away. Do you know in 3 minutes they're back walking around like this? So now, is this a mechanical situation or is it a habit? This is their habit. They don't want to be tall. They want to shrink back a little bit. That could be a personality and a habit. Or I might say, let's put your elbows on the wall, and I'm going to lean forward. Do you see the action that I'm creating through my elbows? And now I'm lifting my upper thoracic spine, and then all of a sudden they come off the wall, and it's very easy for them to keep their ears over their shoulders now. So do you see that's a hardware change?
Okay, so we've had a bit of a studio change, so but we're picking up from here and continuing with Dr. Stuart McGill. For some people, the problem is related not to posture or movement or load, but the pain may indicate that something different, something more serious is going on. Is that the case?
Yes, but it's extremely rare because posture change and movement migrates stress from one part of the body or from one tissue to another. So it's a very effective way at getting at what is pain sensitized. But you're right. Once in a while, the patterns don't fit, and that is the key. The pattern doesn't fit. Something else is at play here. And we have converged and found aortic aneurysms, which is very, very serious. If that ruptures, the person's dead. We've found various spine tumors and other associated tumors. So when the pattern doesn't fit, we investigate a bit further, and if it still doesn't fit, we then send them on to the appropriate clinician to investigate further.
Yes, that sounds like those could be very serious problems. For those who are not in that category and who are those who are having back pain because of posture, movement, load, etc., what's your process? What's the way that you go about understanding the individual's problem and helping them to find relief?
Yes, well, it may, I mean, you're being very specific with motions, postures, and loads, but what you're talking about is life. And it might be the way that they are living their life, unbeknownst to them, is triggering their back pain because no one has been able to understand it yet and offer them an alternative. So if just to go over the general BackFit Pro algorithm, if you will, I simply start by saying to the person, tell me why you're here. I don't ask about their pain specifically. I say, tell me why you're here. And some will tell me about their pain immediately, and others will tell me about their lives and their pressures and things that they perceive is perhaps being the impediment as to why the previous 10 docs they've been to the physio, the psychologist, they've had a surgical consult, they've been to the chiropractor and the massage therapist, and most of them, well, obviously they all failed in getting the person better, and some of them even made them worse. So what were the impediments and why? And if I don't understand those, I will fail too. So that initial extraction of information is it's a real skill. I had a interrogator here as a patient one time. He was an interrogator for Homeland Security in the U.S. His job was to interrogate people to find out if they were telling the truth. And by the end of our interview, he looked at me and he said, "That was the most masterful interrogation. You used every trick in the book. How did you know all of that?" Because we set up our room. I do not sit in front of the patient. I sit at 45 degrees. They sit looking at a fireplace, which is a gas fireplace and it's turned on. At the university, our interview room won an architectural award for its layout and how it was designed to make people tell you, not to make them, but to make them so comfortable that they tell you things that they've never told anyone else before. And some of the stories I could tell you would break your heart. But that's how the assessment starts. And then I get into specific provocation tests and I test alternative explanations. And all the time I'm perceiving, how do they respond to coaching cues? How am I going to coach them? How am I going to affect the behavior change that we need to, I'll give you an example of an exercise addict. Let's say we have a stay-at-home mom, two young kids, young 30s, and she says, if I don't go to the gym every day and ride the elliptical for 30 minutes, I'm going to kill my husband. It's my stress reliever. And then I'll say, okay, you're an exercise addict. If you keep doing that, I can't help you get rid of your back pain because we just proved that was the cause. So do you see, if I don't get it to that level of stopping the cause, we'll fail too. So, or the next person comes in and they're a sloth. And I'll say, what time did you get out of bed this morning? Oh, well, this past week I've been sleeping in a bit, 9, 10 o'clock in the morning. And I say, well, what time did you get out of bed today? Oh, about noon. Anyway, we did an experiment where we put students to bed for up to 36 hours. Do you know laying in bed for 8 hours is the perfect length of time? When you go to bed, you're slightly shorter than when you wake up in the morning. You know, it's a bit more difficult to put your socks and underwear on in the morning than it was to take them off the night before because the spine sucks up fluid in the discs and it becomes a bit stiffer, and it's actually a little bit more painful in terms of triggering. If you've had flu and you've laid in bed all day long, you'll notice your spine is particularly sensitized for pain. Laying in bed will actually increase that hydraulic stress driver to pain. So again, now I've given you the extreme of an exercise addict versus a sloth, and the approach and the intervention has to be very, very different if I'm going to be successful. So there's a lot that goes on in understanding how to get that lasting relief. But it's usually, in a nutshell, stop the cause of whatever it is, give them an alternate way, a movement hack, if you will, to negotiate their life, and then create a program to tune their body with strategic stability, strategic mobility, take the stress out, move well, and become resilient. to the things that you want to do. So that's it in a nutshell, I suppose.
So the answer is not in a little pill. It's not taking a little pill and the back pain will forever be gone.
Well, yes, we would say yes, absolutely, but that's not always true. We've had people who they were stubborn in their recovery. We couldn't understand there was something holding them back. It turns out they had Lyme disease. So when they take a little antibiotic pill, to use your little pill example, that was the missing part of the puzzle. So I'm just giving you examples here where the assessment, if it's thorough enough, will converge. And as I always used to say to my students, if you can't find the cause of their pain, you missed it. Go back and reassess, and you will find it. Pain isn't normal. There's a cause. So it might be a little pill, but it's very rare. And I will say that if you go to the doc and they give you a pain analgesic pill, you saw the wrong person. They defaulted and say, well, we don't know what's causing your pain, but here's something to numb the pain, but it won't do anything for the cause.
Now, for the everyday folk, the average person, you've written a book called Back Mechanic. That's for the layperson. From our discussions and from looking at your work, you have provided training and manuals for the medical community, but for the average reader, everyday person who's suffering back pain, there is your book Back Mechanic. Tell us a bit more about that and how that can help someone to find a solution to their problem.
Yes. Well, I'd written books for my medical colleagues, and then I was asked by a book publishing company, would I write for the lay public? And I thought, well, no, I don't write for the lay public. Celia, it took me 5 years to write that book because it was such a dance between getting sufficient detail, so it's truthful and helpful, versus being consumable. And that was such a dance. But the book, Back Mechanic, guides the reader through a self-assessment, 9 different tests that will help them converge on specific categories. Now, if you are in the category, this is a question of, is it effective? If you're in the category where you've been told now by a medical professional, well, you've tried chiropractic, you've tried massage, you've tried physical therapy, you've tried all of these various flavors, and you failed. The last thing left for you is surgery. Now, if that's the category that you're in, and we follow up with every patient that I've ever seen at the university, so we know our clinical score. If that's the category that you're in, 95% of those people in that category following the Back Mechanic program in a 2-year follow-up will say, we're glad we didn't have surgery, and they didn't. So that's a 95% success rate in those who've been told their last hope now is surgery. 95% of them avoided it, and that we're glad that they did. But we have different success rates based on whether you're motion intolerant and triggered or load tolerant and triggered and that kind of thing.
Back Mechanic and the work that you do, you recommend exercises for lasting freedom from back pain. What sort of exercises would give someone relief, permanent relief?
Well, you're starting to get the answer. It depends on the assessment. So I gave you the example where some people with discogenic pain will get relief by doing short little interval walks throughout the day. Whereas someone with stenosis, they're a bit older now, they will get relief by frequent sitting down bouts of exposure and avoiding the long walks. So do you see how it depends on the
it's individualized.
Very much so. And then there are people who say, oh, well, do Tai Chi for your back pain. Well, a little story on that. When I was younger, Tai Chi wouldn't have done a darn thing for me. I wanted to get strong and lift weights and run fast and all of these sorts of things. And I thrived on that. But now, doing a little bit of balance work, feeling the bottom of my feet, a little bit of footwork, a little bit of stability work for my spine, mobility work for my neck and shoulders, I'm feeling fabulous. Probably the best I've felt for years. Being a professor, sitting at a computer for 8 hours a day was very unhealthy and resulted in a lot of pain. Now that I have a routine myself, that has evolved through the 7 decades now that suits me. But what suits me now didn't suit me in my 4th decade. So back mechanic will guide you through the assessment, and it starts by giving the person a safe place to go. What is a posture or an activity that takes your pain away? It might be laying down in a specific way. It might be sitting in a specific way. It might be going for a walk, tall, proud, swinging your arms from the shoulders in a rather military sort of way. Might be very relieving for some people. Then it coaches them through specific footwork to, if I want to pull a door, I grab the door and I drop step back with one leg. So do you see how that drop step? I'm not reaching forward and pulling with my back. I'm using my hips. It's a very universal. I might be serving a tennis ball, drop step, on the basketball court, boxing someone out, drop step, or now I use the same athleticism to pull a door in a very athletic, pain-free way as an example. Then we might have specific exercises for strategic mobility. So if I am losing hip mobility or shoulder mobility, the movement has to come from somewhere in our linkage. So we will have to coach certain mobility exercises, some stability exercises, and then we might prescribe walking. Walking is a fabulous exercise for many reasons, but it's how you prescribe the intervals of the walking that determines whether the walking causes pain or takes pain away. And then we might build strength in patterns. Does the person have strength to lift and lower, to push and to pull, etc.? So there it is in a nutshell, but the book will guide the person. Now, if the person isn't able to converge on what really works well for them, then I suggest they see one of our trained clinicians. They're listed on our website.
That's pretty interesting from what you're saying there. It's not only specific exercises that we need to do to, keep our backs or give our backs a tune-up, so to speak, but in our everyday life, the things that we do throughout the day, we should be paying attention to that so that we can preserve back health. Is that the approach that you recommend? Not just exercises, specific exercises, but all through the day.
Well, let me give you an example. If I hit my thumb with a hammer like this over and over again, it would be okay for a day. By the second day, my thumb would become highly sensitized. By the third day, all I do is lightly touch my thumb and I scream. Now, would you give me exercises for my thumb while I continue to hit it with a hammer? Of course you wouldn't. What you would do is say, would you stop hammering your thumb? So now the analogy is in life, what are the hammers? Take the hammers away. So that might require some kind of a behavioral change or just a movement hack. So I'm going to give you an example now. Let me turn my computer screen and I'm going to say to you, can we see the bench right there? Now I'm going to say, tie your shoe. And the person, we might have taken them through one of the back mechanic tests, and we've already determined that when they sit upright, they're pain-free, but when they slouch fully down like this, that triggers their back pain. So now I'll say, tie your shoe. And they're struggling into their back pain trying to tie their shoe. It's not possible. So that is the hammer on their thumb or the hammer making their back pain sensitized. So we give them a movement hack. Let's say their hips and knees are good. If their hips and knees are good, I'll say, stand up, put your foot up on the chair instead of sitting on it. Now, take your hips to the target. Watch what happens. When I take my hips to the target, I let my knee drift over my foot. Look at my back. I'm not going near my pain trigger. I tie my shoe, out I come, pain-free in terms of a trigger. So there's a fairly potent but very effective and simple demonstration of a movement hack to eliminate the cause of their pain. Now, if I don't do that, no exercise is going to get my back better. But what I've done is I've created a capacity for exercise to do me good now. So take the hammers away, then formulate a program of strategic exercise, and that's the magic of it all.
A magic indeed. That analogy just opens everything up. It makes it crystal clear that what we need to start first with is a thorough understanding of what the problem is, and that's the only route, or that's the best route to solution. I want to go back to something you said. You spoke about walking, and elsewhere you refer to walking as nature's back balm. Tell us a bit more about that. Why is walking so important for those who want relief from low back pain?
Right. Well, walking is a wonderful exercise, excuse me, for what we call just general spine fitness and the stabilizers of the spine. So if this doesn't sound very nice, but if I took your spine out of you, so if I took a spine out of a cadaver, put it on a bench, it would buckle over and just fall. So if I put guy wires, like on a sailboat or on a cell phone tower to hold the spine up, all of a sudden it would be able to support load and become very athletic with no stress. So the muscles of your torso, now people will have heard the term core muscles or core stability. They form a guy wire which support your spine and allow it to move without stress and in a very pain-free way. One of the very best ways to train and tune the guy wire system is to walk. Now, I'm walking. Imagine when I stand on my left leg to swing my right leg, gravity is trying to drop my pelvis down and collapse. And some people walk with the collapsed gait pattern. But when we coach them, the basic foundational athleticism of building their core and then propelling it very gently with a walk, swinging the arms from about the shoulders, that's why it's a back balm. Now, that is much more true in younger people with discogenic pain who are increasing their spine fitness. In older folks, if they have some of those stenosis and arthritis conditions, standing and walking might be the thing that triggers their pain. And we have to do some preconditioning first to understand the mechanism, and then we might allow the same exercise that caused them pain to then become their cure. Let me give you an example of that. So we're going to call this the park bench decompression. Let's say I'm 70 years old and I get back pain after 10 minutes of walking. So all I can ever do is walk 10 minutes. Well, chances are we can expand that. I'm going to take the heels of my hands, put them on the back of a park bench or a car bumper or a table in this case. And I'm going to move my feet back and I'm going to post down through my shoulders, making myself tall, turning on my pec muscles, my latissimus muscles, and I'm just going to allow my hips to drift forward just a little bit. Now, some people, that will cause even more pain, but in about half of the people, it will relieve their pain. So if it relieves their pain, Walk in the park for not 10 minutes to pain, walk in the park for 7 minutes. Now, instead of guaranteeing pain, you've just guaranteed pain-free success, 7 minutes. Go over to the back of the park bench and enjoy the traction and this little hover for about 30 seconds and stand up. And if the patient says, you know what, I'm restored, good. Go walk for another 7 minutes. You just guaranteed success number 2. Back to the park bench decompression. Do that 3 times, and for the first time in 2 or 3 years, that person has successfully walked accumulated 21 minutes pain-free. So short intervals that don't cause pain guarantee an accumulated ability for more pain-free walking. Now, that works about half the time in an older stenotic type of spine. In the other half, it makes them worse. So then we might use a technique of teaching them a pelvic tilt. So instead of extending their spine in traction, they learn tucking under with just a little bit of a pelvic tilt, and that allows them to walk and accumulate short intervals of success. Again, how do they find that magical sweet spot? We might have them planking on a wall and they learn how to adjust their hips and their low back into that resilient posture that allows them to walk pain-free for whatever interval it is. And then we just build up the successful intervals. So there's a little bit of an essay, I suppose, on a philosophy to guarantee success through cumulative pain-free exposures.
Wow, that when you spoke at the outset about going deep into the subject and understanding it thoroughly, you weren't kidding. You have a thorough understanding. You can give the patient a thorough understanding of their situation, their individual situation, and find solutions. Even on the topic of walking, there's a way to approach it in terms of endurance, motion, and timing that would give best results.
Absolutely, yeah.
Okay, now you've also developed a training program based on a weekly 7-day cycle that may suit seniors in particular. Tell us a bit more about this.
Well, it's been something that obviously I've been studying for over 40 years. And I know myself as probably the best known subject. So I've already alluded in this interview that how my body has thrived has evolved and changed as I've gotten older. I would study people I knew who were very successful seniors. They were successful cognitively, successful physically. What were the features of their lives that allowed them to be 80 years old and still out chopping their own firewood, having a beer, just enjoying life as a very robust woman or man? And it was those people who were moderate in all things through their life. I noticed other features as well. They had routine. They got up in the morning at the same time, and they did something like they walk their dog. First thing, never changes. Every day they walk their dog. We just got right back to interval walking. At lunchtime, they go and walk their dog. At dinner time, they go and walk their dog. Before they go to bed, they go for a short walk. So they have short interval walks, a routine. They get up at the same time every day. They do physical work. Rarely do they do the same exposure 2 days in a row. So after putting all these observations together, I came up with what I call the biblical training week, because it's 7 days and every major religion in the world has a day of rest. So here's the science and the magic of it all. 2 days a week, I strength train. Now, the background to that is now I'm retired. I do a lot of physical work. I chop my own firewood. I just have fun living a rural life. If I don't do something that is demanding of my strength, I come down here to BackFit Pro and I'll do a little strength training session. So 2 days a week, never 2 days in a row, but sometime in that week, I do strength training. 2 days a week, I work on the stuck things, a little mobility training. So I've broken my neck when I was younger, my collarbone, I've uh, broken ribs. I've broken my hip. I'm now hip replaced. I've lived a pretty fun life. But my shoulders need a little bit of mobility work. My neck, my hips need a bit of mobility work. So 2 days a week I dedicate to a little bit of mobility work. 2 days a week, now we're up to 6 in total, I do something for my ticker, something that's a little bit aerobically demanding. So if I split firewood, I've done all three. I've got mobility, I've got strength, and I've worked on my heart. But if I haven't done anything for my heart, I make sure I go for a bike ride, a swim, a ski if it's in the winter, or whatever that is. So there's 6 days out of 7. Now the 7th day, I rest. I don't do anything physical. That is the magic. That is the day that allows your body to adapt. So accumulated stress doesn't accumulate past the tipping point. It only accumulates up to the tipping point, so your body responds with more strength, healing. I don't cross the tipping point to accumulated damage and pain. So there's a routine that I learned from very successful seniors. I now live it myself, and I teach it to quite a few people, and some need a little help dialing it in, but they're very happy that they make the effort.
So my final question is on where someone who wants to go deeper into this subject can go to get more information or even work with someone who has been trained in what's called the McGill method after all of the research that you've done. You have trained others to be able to help seniors and any age, elite athletes as well, to get their back conditioned, to rehabilitate them if they're experiencing back pain or have had injuries. Where can someone go to get deeper into the McGill method and to get support from those you've trained?
Well, the best source of information is our website called backfitpro.com. Just as it sounds, backfitpro.com. And there's 2 portals of entry. If you're a clinician, you enter on one side. If you're a patient, you enter on the other. And there will be lots of YouTube links to videos and interviews and podcasts that I've done, similar to this one today. And there's a few articles there. There's access to my textbooks, which range for mostly for the clinician, but I have back mechanic for the lay public. And there are some videos and training courses and things like that. So it's just backfitpro.com.
Those were the areas that I had to cover. One thing, so BackFit Pro, Back Mechanic, that's available on backfitpro.com. What about Amazon and chapters? Can seniors also pick up a copy on those sites or physical bookstores?
Yes, it's certainly on Amazon. I can't speak to the individual physical bookstores. I don't know.
As we close, is there anything that we haven't touched on that, as a final word to seniors, that you'd like to share?
Nothing other than a little bit of a word of encouragement. Some people suffer needlessly, and I'm not promising that there's a cure for everyone, but most of the time there is some enhancement that can be done to improve their life and expand their pain-free activities and get back to some joy.
Yes, that's wonderful. Thank you so much, Stuart. That's Dr. Stuart McGill. You've been a wealth, a font of knowledge, and I'm sure that many seniors would be happy to have heard all of this and will be running for the back mechanic or to backfitpro.com to find out more and to get on that path to a pain-free existence. No more low back pain. Thank you once again.
Well, Celia, thank you so much for this and all that you're attempting to do through your organization as well. Thank you very much.
Well, so there you have it. Hopefully, there have been some tips and pointers in there to set you on your journey to finding the relief that you have always wanted if you have been suffering with back pain for a very long time. I'm Celia Sanka, Executive Director of the Diversity Canada Foundation, and this has been the Golden Years Fireside Chat Series. The Golden Years Fireside Chat Series is found on GoldenVoices.com. That is the online platform brought to you by the Diversity Canada Foundation. It's a place where seniors gather to focus on issues of importance to seniors. Join us at goldenvoices.com for more in the Fireside Chat series, where we will be focusing on various issues under the theme of living longer and living well. See you next time. Take good care of yourself. Bye for now.